Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The likelihood of a man or a woman dying of coronary heart disease is much less than it was half a century ago, with better treatments and a reduction in smoking. However, as our special guests will explain today, the overall burden of coronary disease continues to grow and it still remains the single leading cause of death in Australia. Professor Will Parsonage is Clinical Director at the Australian Centre for Health Services Innovation and Senior Staff Cardiologist at the Royal Brisbane and Women's Hospital and St Vincent's Private Hospital. Associate Professor Sarah Zaman is an academic interventional cardiologist at Westmead Hospital and the University of Sydney. They are co-authors on the Lancet Commission on Rethinking Coronary Artery Disease, and they have written about it for the MJA's Insight Plus, and they join me now. Your article is titled "The Need to Urgently Rethink Coronary Heart Disease." Why is there this need and why is it urgent?
So thanks for the question. The reason is that we know that coronary artery disease is one of the major killers globally, and the mortality rates are actually increasing, particularly in certain areas such as low and middle income countries, but all over the world. And as a result of this, we are spending billions of healthcare dollars trying to address coronary disease. But what we found throughout looking at the evidence in this commission is that actually we're addressing the illness far too late. So we're looking more at intervention once we have advanced coronary disease. And we really wanted to shift the focus back to early prevention, recognition, and intervention very early in the disease course.
So what does that look like? So what needs to change?
So many things actually need to change. It's a huge shift in focus, both in how we deal with diagnosis and recognition of coronary disease, and also in the workforce that we have to address coronary disease. So if we think about it, at the moment, the whole workforce is shifted towards late intervention. So we're focused on recognizing things like acute heart attacks, acute coronary syndromes, and we have excellent strategies to do that. So we have primary PCI or stenting, an emergency stent for someone who's having a heart attack, and that does save lives. But throughout this commission, we've really highlighted that that's really, that's an end stage manifestation of coronary disease. And in fact, we should have focused our workforce down to early primary prevention, so more in the community, more in the primary care space, to really improve the recognition of risk factors much earlier in life and preventative strategies.
So to address things early on, what does that look like?
Yeah, I think we were struck very early on when we first sat down and talked about the commission. And I think originally the commission was going to be titled Ischemic Heart Disease. And when we actually sat down and thought about that, we realised that even that term is somewhat problematic. And it really illustrates the fact that for atherosclerotic coronary disease, as Sarah said, we focus very much on ischemia as the manifestation of the disease. We talk a lot about prevention, but if you actually look at what we do, we've underemphasized the value of preventing the disease before ischemia occurs. And yet the tools that we already have, and probably the tools that we foresee being developed over the next couple of decades, actually position us really well to actually detect the disease much earlier, way before ischemia occurs. And that's really why within the commission, the title of it changed, and we started talking about atherosclerosis as the disease rather than ischemia as the disease. And in fact, for people who read the commission, they will see that we've actually come up with this sort of bold idea of reframing the whole condition as atherosclerotic coronary artery disease, hopefully shifting the way people think about this, to think about atherosclerosis rather than waiting for ischemia to occur. So in terms of the tools that we use, we know up until now we've used risk scores, and there are multiple different risk scores which we know are problematic. They were derived in small populations that are not really representative of our contemporary populations, with different profiles of risk factors, different demographics. On the whole, they tend to overestimate risk to some extent, but they certainly don't target risk stratification very well, and they therefore don't target therapies. We also have great new diagnostic tools that are increasingly available for detecting atherosclerosis. In my career, I've spent a lot of time looking for ischemia, doing functional testing, some form of stress testing. But we now have accessible ways, to a great extent largely with CT imaging at the moment, to actually detect atherosclerosis much earlier in the disease process and way before ischemia intervenes.
Yeah, exactly. Well, and I guess what we're really trying to highlight here is that atherosclerosis isn't a condition that suddenly occurs in middle or late life. It's actually a condition that can start in utero, in childhood. We've got studies showing that atherosclerosis can be detected in children and adolescents. And so we really need to refocus that screening for atherosclerosis to earlier in life and start the prevention process earlier.
So why hasn't this shift been made before?
That's a really good question. And it's got lots of layers, I think. I mean, I think as Sarah said, our systems have evolved and are now heavily developed towards dealing with ischemia. We have very good, in a high-income country like Australia, we have great systems for dealing with the acute and chronic manifestations of ischemia secondary to coronary atherosclerosis. So where I sit here in Brisbane, within 10 kilometres in any direction, there are 3 publicly funded labs who, if I sit here and have an acute coronary syndrome, I can go in any direction and I can get a primary PCI done pretty quickly. And so those systems are very good. We need those systems, and they've been invested in very, very heavily. But what we haven't invested in so much is the services that we need in terms of early detection of atherosclerosis and then treatment of individuals who are at higher risk so that we can actually prevent those ischemic events from occurring, be they acute or chronic. And of course, we have a growing, armamentarium of ways of doing that, spanning potentially right across from government policy to improve lifestyle and diet through to behavioural change methods and so on, and then into where appropriate pharmacologic therapies for the known modifiable risk factors like hypertension, which we know is treated better but still undertreated, where necessary lipid lowering and a sort of burgeoning array of treatments for risk factors that we know modify outcomes.
So what exactly does early detection look like?
So I guess in terms of early detection, so if we're talking about detection of the disease itself, often that does involve imaging. So we have spent quite a bit of time analysing the evidence for imaging in this space, and that can be with CT scanning to look at either coronary atherosclerosis, and there's more advanced techniques coming out to reduce the radiation involved with CT scanning, and also to improve the detection of what we would say would be aspects like vulnerable plaque that might better predict coronary events. So screening might look like the use of more imaging at an earlier age, but perhaps guided by some other risk factors or risk scores. But it might be different imaging modalities that are still yet to be developed, and there's a lot of research that's needed in this space.
I mean, I think the other thing is, the big question is who to screen. I think at the moment we know how to screen. We know we've got great investigations that can detect very early atherosclerosis, but as with any effort to screen, it's who you screen is the challenge. And I think that's the exciting area, I suppose, for future research, is to decide where that investment is going to be best placed. So where can we come up with an effective but also sustainable and cost-effective screening strategy? And I think when I've thought a lot about this, I've looked at the parallels in other kind of diseases, and it's something of a paradox if we think about it. We've just got the lung cancer screening program being rolled out, and we've got long-standing screening programs for bowel cancer and breast cancer, but we still at the moment don't have any strategy for screening for coronary atherosclerosis, which, as Sarah started by saying, is still the leading single cause of death in this country. And it's largely because there's a lack of evidence about how to screen. And I think in many ways the technology has sort of run ahead of us, the imaging technology. And I think, we're also now in this new era where with big data and maybe information from polygenic risk scores and so on and so forth, showing lots of promise to identify what might be the population that need to be screened and where will we use those advanced imaging techniques, because clearly they're still complex tests, they're still complex and expensive tests. It's not going to be as simple as everybody at a certain age having a CT coronary angiogram. That's not going to work. I haven't done the maths, but it's not difficult to realize that won't work. But to do that sort of investigation in particular groups that may be defined as higher risk using other criteria is certainly feasible, and that's a sort of really exciting area for research in which we need to do, and that's it's the other area where we need to invest. We need to invest in investigating those things so that we can in the future come up with as I say, a sustainable and effective and cost-effective screening strategy.
And I think, Will, you make a really good point there in that one of the key messages of this Lancet Commission is the call for more investment in research, and that the investment should really match the burden of disease. And we've had lots of investment in other screening programs, and we need the same government or organisations to invest in screening for coronary artery disease, which is basically the leading killer in Australia.
So, why do you think there? I mean, you have mentioned why in some respects, but why isn't there a larger push for early detection and a standardised screening program in Australia?
I think Will's sort of highlighted some of the issues around a standardized screening test or way to do that. And the reason for that is at the moment the lack of evidence, because these sort of trials take a huge investment. You need really long-term follow-up, and because as you can imagine, if you screen a younger population where the risk of events may be quite low, you need to recruit a huge number of patients to these trials and follow them up long term to then show a benefit in terms of outcomes. And a lot of evidence that we use in cardiology, you do need to have that hard outcome benefit. So it's challenging to do these trials, which is why they haven't been done yet, but not the reason, it should not be the reason why we can't do these. And hand in hand with that, we've already got these huge improvements in technology and imaging that we can use, polygenic risk scores, other CVD risk scores. And so if we can then get that investment, then hopefully these clinical trials could be done.
And also, you mentioned earlier that the risk scores overestimate risk. Could there be an accurate way of determining who is at risk and therefore needs screening?
I think the problems with existing risk scores, I think, have been highlighted by a number of people, and generally the trend is that they often overestimate risk, and I think, as I mentioned before, it's largely because of the populations that those risk scores have been based upon, which don't necessarily reflect contemporary populations and risk factor profiles and the changing demographic of the population. The difficulty is that those to come up with new risk scores takes a long time, because generally they require long-term validation studies if we're going to come up with new risk scores. So I think the hope is that those risk scores will continue to provide a basis for identifying broad bands of risk, and then newer methods of risk stratification will help to modify those. And so, for example, something like coronary calcium scoring can be seen as a risk modifier, if you like. It's and that's been incorporated in the recent revision of the risk score here. But I think the hope is also that some of these new areas, be it polygenic risk scores or other health data that becomes available through big data methods, may be able to enhance those risk scores to give us a more refined and individualized measure of risk in the patient that sits in front of us.
I mean, the other thing with CVD risk scores is that it's great to help predict 5-year, 10-year risk, but frequently we have younger patients who have cardiovascular risk factors. They are at risk. There's, some of these people will have a 30-40% chance of developing atherosclerotic coronary disease in their lifetime, and yet the 5-year risk might be only a few percent. So it still doesn't help with what we do for that patient and how we tackle their prevention, whereby we want to stop them from having an acute coronary event.
So, bowel cancer screening has made a huge impact on cancer amongst individuals. What difference potentially could early detection make on heart disease?
So, if we had a better way to early detect coronary disease, I think it would have a huge impact globally. So, if we can halt the condition in its course, or ideally, we have new strategies and therapeutics that are coming out that maybe even regress coronary plaque, then that would be a huge impact. Lots of lives saved, reduced burden of acute coronary syndromes. So and on a global basis, that would be millions of lives saved.
Wow, that's amazing.
I think there's two other important points. So I guess we've touched on it, but one of the major messages of the Commission is that whilst it's we really do talk to early prevention, early detection and treatment, one of the other major impacts on reducing coronary disease is if we just implemented what we already know to be effective. And I'm sure Will can talk to this much more effectively than I can. But there's a huge burden of cardiovascular risk factors out there, people who have established coronary disease, and we know we have therapeutics that can lower the risk of mortality, morbidity, yet we don't implement these worldwide. Will, thoughts here?
No, I agree. I think we're very aware of the fact that we do. If we take secondary prevention in people who have been unfortunate enough to have an acute event, we know that the immediate care that they receive on the whole is extremely good, and we have good access. As I say, in a high income country here, we have very good access to very high level services. But we do know that beyond that, there are some significant limitations, in a sense that there's a sort of sharp drop off in preventive therapies, even as near as a year after an acute event. And the AIHW have published some very nice data just in the last year or two, showing those individual patient pathways using linked administrative data, which does have some limitations, but it gives quite a surprising picture of what the real world treatment of patients with acute events. And we also know that there are still substantial gaps in terms of continuation of therapy for modifiable risk factors, such as hypertension and lipids. And there are some really nice and simple and exciting interventions that have been shown in research trials to improve uptake and improve continuation of those approaches. And they're sort of non-traditional. We've very much relied on office-based medical care to drive these things, and yet we know that there are different methods of delivering those preventive interventions in communities that don't rely on a doctor sitting in front of a patient in an office, which we know is a service that is extremely stretched. We're sitting here in the middle of the flu season, and my hospital's full, and GPs are buckling to look after the winter flu season. It's very difficult to expect everybody that needs supervision of their hypertension treatment or lipid lowering to be able to get an appointment with their GP. And so I think we have to rethink those systems as well. I guess the other point we haven't covered, I suppose there were a couple of things that came to mind. Coming back to your question about why haven't we done this, I think something I've been thinking about a lot is to some extent, there's a tendency to think that we're winning. There is no doubt that, somebody my age is much less likely to die of a heart attack today than I was 40, 50 years ago. Now, there's lots of reasons for that. A lot of it's public health measures. And a good example of success, we've seen massive reductions in smoking rates, for example, and probably a great deal of the improvements that we've seen have been attributable to that, as well as better treatments for people who do have events. And so there is this tendency to think that, we're winning coronary disease and that we just carry on doing what we're doing. But in fact, although those facts are true, that doesn't do too much for the burden of disease, because the disease is still very prevalent. People are living a lot longer. And so the overall burden of atherosclerotic coronary disease is still huge, and it's still certainly globally going to grow. It's sort of plateauing in this country, but it's still going to create that huge demand in the future. And for the reasons I've just been talking about, our constantly stretched health services, just carrying on doing what we're currently doing is not going to be sustainable. And of course, we've got a growing burden of emerging risk factors through obesity and increasing prevalence of diabetes and so on, which are very quickly replacing, the advances that we've seen attributable to, reduced smoking rates and so on.
Yeah, and just to echo that, I think, as we shift this mindset away from ischemia and late stage disease towards prevention, we really need the government and public policy to move alongside with clinicians and healthcare systems to really target that. So alongside promoting, active lifestyles and better nutrition to try and reduce obesity and diabetes, we need that public health policy that actually improves nutrition at that level or allows access for increased physical activity. So we need the government to walk alongside us as we make these changes and that shift in mindset.
The other thing we haven't talked about is inequities.
Yeah, well, I think throughout the commission, it's weaved throughout it the fact that the burden is still high in middle and in high income countries, but actually there's a huge increase in coronary disease morbidity, mortality in low and middle income countries, and it's a little bit of a unusual paradigm in that you often get rises in obesity and diabetes, particularly in children in low and middle income countries, but it's coupled with malnutrition and lack of healthcare services. So it's a huge burden in low middle income countries, and we do need to have the focus there to be both improving healthcare delivery for acute coronary syndromes and heart attacks, but also focusing in on that prevention of both malnutrition, but also obesity and other risk factors.
Yeah, I think, the Commission very much had a global perspective, and as you know, the authors were from all across the world, and we were mindful of the fact that we were producing a document that had to take a global perspective. But I think also it was a great opportunity to sit down with colleagues from around the world and realise that within our countries there are significant sources of inequity as well. I mean, obviously here in Australia, I mentioned I'm much less likely to suffer a heart attack now than I would have been sitting here 40, 50 years ago. But it's also true to say that, a First Nations person my age is 4 or 5 times more likely than me to have a heart attack. And that's our, most striking source of inequity within our high-income country. But there's also problems with access to these high-end services in regional and remote areas as well. And we know that does impact certainly on the care that people receive in harder to reach areas, and that impacts on outcomes as well. So for us here in Australia, looking at the Commission and saying, what are we going to do about it? That's a big part of what we need to continue to address and look at as well. We were lucky that we had 3 co-authors, including Sarah as the lead author on the Commission, 3 Australian co-authors, so myself, Sarah, and Steve Nichols in Melbourne, and we'll all be taking part in a symposium session at the Cardiac Society of Australia and New Zealand meeting that's being held here in Brisbane starting on the 15th of August.
Thank you to my special guests, Professor Will Parsonage and Associate Professor Sarah Zaman. The MJA acknowledges the traditional owners and custodians on the land on which we live and work across Australia. This podcast was recorded on the lands of the Wongal people. I pay my respects to their elders past and present. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.